Welcome, everybody. Rush University Medical Center, Division of Nephrology, Renal Biopsy Conference for August 22nd, 2024. We do not have a CME code today. This conference is being recorded. I see lots of new names in here, so welcome, everybody. We appreciate you joining us. If you need to be on our mailing list, send us a direct message or in the chat your email, and we'll put you on the emailing list. And remember, we have a YouTube channel, which these eventually get posted on. We're getting close to 100. And they're now organized by disease category, thanks to Dr. Baxi. So we've got a long case today, a lot to discuss. To move ahead, we have nothing disclosed and privacy's been preserved as usual. And I wanted to show this first. This was at GlomCon a couple weeks ago in Maui. Unfortunately, Dr. Glassick's not here because I think he looks the goofiest, although I think I take a close second. Bill, of course, is too vain to put stupid glasses on. But also we have joining us that were there at GlomCon, Dr. Raja Sakaran and Dr. Obadi, who have been religiously joining our conference and now will be co-hosts as well. And it was great to see them in Maui. So that's the five of us having a lot of fun.
Looks like an Elton John wannabe contest.
I don't know which one, but Rocket Man. Okay, so I think Bhavna's going to read the case.
Yes.
All right. So we have a 42-year-old white male with idiopathic thrombocytopenia and ankylosing spondylitis, HLA-B27 positive, and on Humira or adalimumab and occasional prednisone, who presented with fevers, shortness of breath, hemoptysis to an outside hospital, and discharge on doxycycline and ceftonir for treatment of community-acquired pneumonia. Over the next few days, he continued to have fevers of up to 103 and hemoptysis 2 to 3 times a day. He also developed an erythematous, non-pruritic, and painless rash over his head and neck, spreading to his chest and upper extremities. On admission to Rush, the serum creatinine was 0.95 milligrams per deciliter, and a urinalysis demonstrated proteinuria and microscopic hematuria. A bronchoscopy demonstrated diffuse alveolar hemorrhage, and malignant and infectious studies were negative. Dermatology performed a skin biopsy, which demonstrated perivascular and interstitial dermatitis consistent with interstitial granulomatous dermatitis. On the 6th day of admission, his creatinine increased to 1.35 and nephrology was consulted. His ROS was positive for fevers, fatigue, cough, shortness of breath, hemoptysis, and rash. His past medical history is significant for ITP, ankylosing spondylitis that was HLA-B27 positive. No surgical history. His only medications was Humira and THC gummies. No known drug allergies. He last used tobacco products 3 months ago and last used alcohol 1 year ago. And his THC gummies, but no other recreational drugs. His family history was positive for no known family history of IBD or autoimmune disease. On exam, he was afebrile, blood pressure is 125/80, pulse was 74 beats per minute, respirations were 22, and he was saturating 93% on room air. He weighed 98 kilograms, height 6 feet, and a BMI of 33 kilograms per meter squared. On exam, he was alert and no acute distress. He had no oral mucus lesions. His respirations were non-labored. He had coarse breath sounds bilaterally. Cardiac exam was unremarkable. He had no lower extremity edema. On skin exam, he had diffuse annular plaques with central clearing involving the face, the neck, the upper back, upper chest, and forearms. He also had annular targetoid macules involving bilateral palms, and nothing significant on neurologic exam. Lab data is significant for CMP with sodium of 134, potassium 3.8, chloride 103, bicarb 24, BUN 14, creatinine 1.60 milligrams per deciliter with an eGFR of 53, glucose 93, total protein 6.5, albumin 2.5, adjusted calcium 9.4, T-Billy 0.7, alk-phos 50, AST 40, and ALT 50. CBC with WBC of 8.50, RBC 3.95, hemoglobin 11, MCV 82.3, platelets 246, and PT, INR, and PTT were normal. LDH 313 and haptoglobin of 350. Iron study showed an iron sat of 12% with ferritin of 980. UA showed 30 milligrams per deciliter of protein, 3 plus blood, 123 RBCs, and a UPC of 241 milligrams per gram. This was his skin biopsy.
Yeah, so this shows a perivascular and interstitial dermatitis. There was no vasculitis.
Cool.
Serologic workup showed a C3 of 157, C4 of 20, ANA, anti-double-stranded DNA, anti-GBM, and anti-CCP, and C-ANCA, PR3 ANCA, and antihistone antibody, antiphospholipid antibodies, Hep B, C, and HIV were negative. ESR was 65, CRP was 205, and a P-ANCA was positive with titer 1 to 640, with the MPO ANCA greater than 8. CT chest with IV contrast showed extensive bilateral ground glass opacity, predominantly in the peripheral and subpleural distribution of both lower lobes. Bronchoscopy study showed bronchial culture with normal respiratory microbiota, and fungal culture and AFB cultures were negative. PCP was negative, and BAL cytology was negative for malignant cells and showed benign bronchial cells and alveolar macrophages. The patient was started on empiric treatment with IV methylprednisolone 1 gram and underwent a renal biopsy the next day.
Any questions on the protocol?
How soon was his Humira started? Was that a new drug for him, or and how when did he get it in relation to his presenting symptoms?
He'd gotten it a few weeks before. I think he'd gotten 2 doses or so from what I can recall.
Okay. And then I've got a question for David. Because the biopsy report said this granulomatous dermatitis, were granulomas there? And then would you think about that as more of a manifestation of a vasculitis, even though there was no vascular inflammation?
So this is read by a dermatopathologist, not by me, but it doesn't report any granulomas present.
I mean, for sure, there was no leukocytoclastic vasculitis, right, David?
Right. It explicitly says there's no erythema multiforme or vasculitis.
Right, which is usually what, a venulitis for the most part, right?
Yeah,
Yes.
just the granulomatous dermatitis kind of confused me a little, and I was trying to get some.
No, I know. Trust me, we we were thinking the same thing, and the report is very specific. And when even the vessels on the biopsy didn't really show a vasculitis, but yeah, it has this granulomatous appearance in the interstitium and perivascular. But I hear you.
Hey, Bill, since you're on, you want to tell us what your thoughts are?
Yeah, sure. Thanks, Roger. My first thought is that this is a person with ITP, and as soon as you hear that, you kind of think that they are going to maybe blossom into latent lupus, and sometimes we see or blossom into lupus from latent lupus, and thrombocytopenia can often be the first manifestation of their lupus. And then you see that he got Humira for I think his psoriasis, and Humira also is known to activate the immune system in terms of, I thought, even a lupus-like syndrome. Or possibly even a vasculitic-like syndrome. So when
The Humira was really more for this spondylitis, his rheumatoid arthritis or arthritic process.
his ankylosing spondylitis, sure. Yeah, I may have said psoriatic arthritis, but I misspoke. But he gets this other medicine, and that's known to sort of charge up or rev up the immune system. So I was surprised by serology. I thought we were going to have a positive ANA, and it was going to be this sort of lupus overlap alveolar hemorrhage type of syndrome. I have to think I'm surprised. His ANA is negative, his complements are normal. But what really is there is that his MPO ANCA is positive, and you put that together with a skin rash, with AKI, with hematuria, with proteinuria, with alveolar hemorrhage, and this is sort of screaming out in a ANCA positive vasculitis. Whether that is going to be due to Humira or not, I think it's going to be a question that we'll have to figure out. But I think that's probably the most likely thing that we'll see on biopsies. We'll see a necrotizing, segmental post-immune type of lesion. Some of the ones that are overlap or drug induced, like with hydralazine, often have high titers of both the MPO and the PR3. And they often can have some background mesangial deposits, even though the main pathology is still a post-immune segmental, crescentic vasculitis. And so we might even see something like that, where there may be some background mesangial deposits here too, similar to a lupus-like lesion. But I think the destructive lesion causing his AKI in this case is going to be segmental necrotizing post-immune, consistent with ANCA vasculitis.
When we see, hydralazine, the classic kind of drug-induced vasculitis, we often see a lot of serologies. I don't know if anybody knows if and when vasculitis is associated with Humira, is it as immunologically active or not? I don't know the answer to that. I think that if this patient were on hydralazine, I think it would be a little unusual to see only an MPO. I don't know if anybody knows. Now, the other thing is that unfortunately, this is our Rush lab only gives us the MPO greater than 8, so we don't know if it's 9 or 900. I think that does have some relevance. Our outpatient lab fortunately gives us an ELISA, gives us a better number, but that's where we are.
And for the granulomatous part of the skin rash that was listed in the report, but that David didn't see, the reason I was just getting at that is you think, okay, if he has granulomatous skins, then it might be the granulomatous vasculitis, which you would expect to be more PR3 positive, and his PR3 is negative. So it doesn't quite fit there either, but it's still part of the whole process, I bet.
Let me ask Dr. Rajashekaran and Dr. Robati, have either of you seen Humira-induced vasculitis? Just speak up.
I have not. I'm actually seeing hydralazine ANCA vasculitis, and it was both ANA and antihistone positive with positive PR3.
Yeah.
So I was wondering, was antihistone checked? I mean, it was negative here. So yeah, that was just last week. But no, I haven't seen the Humira before.
Now that's interesting because PR3, usually with hydralazine and many of these drugs, it's MPO. Occasionally PR3, but that's a little more unusual.
Yeah, so Roger, thank you for having me. When I first read the stem, I said this is a 40-year-old white male. He's got ankylosing spondylitis. He's on Humira, and he's got a rash. And there was a high pretest probability that this is IgA or IgA vasculitis. But really, the pattern of the rash and the absence of vasculitis in his skin biopsy kind of threw that away. But it's still very likely that he can have an underlying IgA dominant pattern, apart from everything else that's going on. But no, I haven't seen about Humira and ANCA vasculitis.
Yeah, Dr. Reen is making the same point in the chat there.
Was there a GBM antibody checked?
Yes, it was negative.
Oh, there it is. Sorry, I missed it. Thank you.
So can I interject something, Roger?
Yeah, of course.
So, Roger, when we were discussing this, we found a great article and it talks in particular about TNF alpha. And the most, common one associated with vasculitis is infliximab, but adalimumab is second in the list, at least in this study. The interesting thing to me was the most common finding as far as vasculitis was leukocytic classic vasculitis. It was like almost 50% of them. That's the presentation.
Skin.
With skin, yes. And the next most common, actually, with the adalimumab was HSP. So the IgA dominant, is an obvious, it would be an interesting thing that the biopsy might be helpful with. For sure, if I doubt they did fluorescence on the skin biopsy. It would be interesting to see if there was any IgA. But ANCA-associated vasculitis was like 15%. It was actually not real common. And there was no mention as to how often the kidneys are involved. And there was no mention about what the level of ANCA is in these particular patients, unlike what's talked about with hydralazine and propythiouracil and things of that nature.
It's hard to ignore, these drugs. We've seen a lot of lupus-like reactions, and I've not seen a vasculitis. Pravir says he's seen one.
The other interesting thing was that I found from actually the article that you pulled out, Roger, is minocycline can cause an ANCA vasculitis, and I looked up doxycycline. It has a similar kind of activity as far as antimicrobial, and yet with minocycline, it clearly says vasculitis. With the doxycycline, it doesn't really say that, but it's interesting that he gets put on that, and then then the rash develops. Same thing with the cephalosporin.
He was on minocycline?
No, he got doxycycline. That's
Oh,
why I say
doxy. Got it. Yeah, I vaguely remember the minocycline reference, but I mean from the past, but I haven't thought about it in years. Yeah, you're right. I've seen that. And the list of drug-induced vasculitis is really, really long, and you never know how many of those are just associations versus, you reported a Cipro years ago,
quinolones, yeah, years ago, and those
quinolones,
right.
not very common. A lot of people get quinolones, but I think some of these are real. I think some of them might not be. But
Again, with many of these things, even with quinolones, when we looked at that paper, it's skin manifestations more than anything else. Even levamisole, I mean, when you look at it, I mean, it's mostly skin manifestations, and occasionally can involve involve organs.
so our DD right now is a pure ANCA kind of posse-immune or something a little bit more drug-induced. We may see more, as Bill brought out, or we may even see an IgA, as Arun and others and Dr. Reen pointed out. So I think it's a pretty broad differential. I think we ready for the biopsy for the wheel? Oh, have we seen? I'm sorry, we finished all this?
The only thing left was, I think, the
Yeah,
X-rays.
just showing the images. Sorry, we kind of went through all this already, but
Okay.
this was the
Yeah, this
chest.
just
Oh, I'm
shows
sorry. Yeah, we had them at the end here just to show you that. Yeah, I'm sorry. It's very important. I mean, to get a good idea what we're talking about here. I personally don't think this is subtle pulmonary findings, at least on X-ray.
I think this makes a great example that the X-rays not very helpful in the sense that it shows evidence of you can see these pulmonary infiltrates throughout, and yet the hemoglobin's 11. And this is kind of one of these old adages. The X-ray doesn't really help you tell you how bad the hemorrhage is. I mean, here's a guy who has all kinds of abnormalities on X-ray, and we'll have, I think, the CT scan is next, and you can really. My pointer's not working, but all of these kind of hazy areas, that's all pulmonary hemorrhage. The darker areas are actually, not showing any alveolar hemorrhage, but wherever you see it's kind of fuzzy, that's all alveolar hemorrhage. And yet the hemoglobin is only 11 in this guy, and he'd had this going on for a few days. So, the point is that you can have terrible bleeding with a low hemoglobin and iron deficiency and have almost normal looking radiographs. And
Yeah, well, this is
in this
kind of, I
case,
mean,
you've
that
got
is,
horrible looking radiographs, and he's got a hemoglobin of 11.
and I think that is a really important point. You can have a normal X-ray and still have significant pulmonary hemorrhage. This does not a normal X-ray, and he's not anemic, but he does have iron deficiency, which is, described with chronic pulmonary hemorrhage is more often, I think, in good pastures and the like. But it's hard to say. His saturation was what? He was 93%?
His saturation was 12%. So
No, I'm sorry.
It was
Yeah,
on the
his
lower
O2
side.
His O2 sat was 93% on room air.
That's right. But
So not normal, but not terrible.
Oh, I'm sorry. I thought you were talking about iron saturation.
Yeah,
Never mind.
yeah. Well, no, I did say before. So he's iron deficient and everything else. So it's pretty interesting. And we're going to get into all these factors later in the talk. I think that we will go ahead and take a look at the path. Is it time for the wheel?
Oh, yes, it is. Let's go to the wheel. I can't read it, but this will be there until she graduates. So let's go to the wheel here. Give me a second. Spotlight. All right. Go ahead.
All right, great wheel. Michael.
I don't think Michael's been picked in a while. Give me a second here. All right. Give me a second here, Michael. Let me unmute you first, and then I'll give you control. Go ahead, try it out now.
Testing, testing.
Perfect.
Perfect.
Perfect. Now I'm going to give you control. Go ahead and click. Yep, you're controlling the screen now. Go ahead.
Okay. I tried clicking.
There you go.
Okay. All right, so this is trichrome stain. We have not a lot of fibrosis from what I can tell here, like very, very minimal. I see one glomerulus here. But yeah, I really don't see much fibrosis.
Yeah, yeah, Michael, very, very minimal, if any at all. Yep.
And given the fact that our pretest probability for what we're going to see is pretty high on ANCA vasculitis, the other big part of what we want to gather from this biopsy is the degree of fibrosis. And so this might be the most important slide that we see, when we're going to probably be talking about treatment later.
Yeah, yeah, absolutely. This is H&E stain, and this does not look great. This looks like fibrinoid necrosis right here. The glomerulus, because of the fibrinoid necrosis, I mean, the capillary loops here aren't, very open.
Yeah, so I think in the top
Crescent.
half, that's probably a crescent forming. That's all parietal epithelium.
Okay.
Yeah, down through half of it. I'll keep going down. Yeah, all that's parietal epithelium. So you're just left with a little portion of the glomerular tuft there at the
Gotcha.
bottom. Yeah.
And Michael, is it like, do you feel like and maybe hard on this one, is it more segmental? Is it global?
I would say, I mean, this one maybe more segmental. It's only half of it, but at the same time, it kind of does take up almost 50% of the glomerulus. So I don't know, hard to tell for me.
And that's that's Rexus at the bottom there, right?
Was that Roger?
That's Rexus at the bottom of, 5 o'clock.
Or that's just what's left of the tuft and it's compressed. I don't see neutrophils or.
I see little black dots, and that's usually Rexus in this. That's
Oh.
all.
Oh yeah, I think that's a
thought-
little stain precipitate. Yeah, right there. Yeah.
Okay.
Yeah. Little glue or stain.
It's another H&E stain, and the glomerulus here. This looks like a crescent to me.
Yeah, it's mostly fibrin, so again, another segmental necrotizing lesion there.
Okay.
And that has some chirectic debris at like 7 o'clock. Yeah, right there. Yep.
Okay. I don't know what this is.
That's a red cell cast.
Okay. It's
Yeah.
massive. Okay. And then these are just red blood cells here?
Yeah, red cells there. They're probably filtering into that tubule there, adjacent to it. Yeah. Yeah, that's a red cell cast.
Sounds good. Another glomerulus, this one looks much better than the others. The capillary loops look open. I don't see a lot of mesangial expansion or hypercellularity. I don't see any fibrinoid necrosis here. Based on these cuts, I can't really tell if the tubules have ATN or not, honestly.
Yeah, there's some kind of a chattering in there. We'll see them on the PAS stain. But for extent of the necrosis, three out of the 9 on the light had necrotizing lesions. Okay.
And then this is a Jones stain. And is this the fibrinoid necrosis here?
Yep.
Okay. I don't see holes anywhere, or spikes.
What do you see?
I just see the fibrinoid necrosis kind of like smushing the.
Well, the hallmark of that is really something else, and that's the breaks in the basement membrane. You see them?
Oh, right here?
No, up at the top. Yeah. There's a
Okay.
couple areas of
Yeah,
break
right
in
there. See, it comes to an end. Yeah, it should be an intact capillary.
I see.
Yeah.
I mean, the idea is there's some destruction, and then then fibrinoid pours out into Bowman space, and you get all this reaction, et cetera. So these are pretty nice breaks. Sometimes you actually see the basement membrane floating in Bowman space.
Interesting. Okay.
Sometimes David does a better job taking pictures, but I guess we don't get it this week.
Another
I had an off day.
Another H&E stain. Are these red blood cell casts?
Yep.
Yes.
Okay. And then I don't know. I don't really see necessarily, maybe a little bit of sloughing here in the tubules.
Yeah,
No.
I think we have a PAS stain. We'll look for the brush border. Yeah, there we go.
Yeah, this is definitely sloughing. So this is ATM.
Yeah, lots of brush border, thinning of epithelium.
Yeah, I don't see any glomeruli in this picture.
Yep.
Okay. And then it looks like this is a negative for IgG, and actually here it says it's negative for all of them on immunofluorescence.
Yep, completely negative.
Yeah, kind of gets rid of the IgA potential. It's important.
And then EM, the urine space is here, blood space is here, and then looking at the podocytes, it looks like there is some podocyte effacement here. I would say actually pretty diffuse podocyte effacement. And I don't see any deposits in the GBM.
Yep. And where's the mesangial area?
Okay.
Okay.
So we had the fibrinoid necrosis and segmental lesions. So we have some necrotizing vasculitis and a little bit of ATN.
Good. So necrotizing post-immune glomerulonephritis with some ATN. Bill, you were saying something?
No, I thought post-immune was important to point out.
Yeah, I think that's the buzz term here, post-immune.
And it's crescentic. I mean, not just necrotizing, but crescentic as well.
Yeah, it is. And
With minimal scar.
we're going to skip the discussion of when you call something crescentic because I agree with you. But yeah, there were some crescents, absolutely. So we're going to jump ahead to poll number 1. How would you treat this patient? Remember, the patient already got pulsed with high-dose steroids. Would you plex the patient? Also give oral steroids with either cyclophosphamide or rituximab. So number 1 is really about plexing, the additional plex, or 2, oral steroids and oral cyclophosphamide. Number 3, oral steroids and rituximab. Or number 4, any of the above with avacopan. Remember, nobody sees your vote, so please vote. Getting a nice representation here. Hardly a mandate too, which is fun.
Very interesting.
Yeah. I think it's very interesting. They can't see it yet, right?
No, not yet.
We'll just talk about how great it looks for the next 5 minutes.
All right.
Pretty good spread.
Yeah, we'll stop it. Give a
Okay.
few more on 60%. All right, there we go.
So assume you can see it. We've got the highest is Plex with steroids and either cyclophosphamide or rituximab. Coming in close second is steroids and oral steroids and cyclophosphamide. Coming in third is steroids and rituximab, and coming in fourth is any of the above. 20%, 21% of people actually tied with third would like to give something with avacopan. So we'll get back to those a little more specifically. You can advance to go back. So yeah, Bill, what would you do here with that? What would you do?
Yeah, I think there's a lot of nice options. The time I make sure that we do plex is if it's severe alveolar hemorrhage, meaning even though this wasn't proven in the Pexavas trial, there was such a minority of patients with severe alveolar hemorrhage, they weren't able to prove that it did or didn't work. And so if somebody's got intubated or they're on quite a bit of oxygen, that's when I lean towards making sure there's plex. From a renal outcome, I try to do plex if it's severe enough AKI where the creatinine is high that might require dialysis, but also making sure that there's enough viability based on the biopsy and knowing that it's AKI, not all progressive CKD. So I don't think I do plex here, is my point. I don't think there's severe alveolar hemorrhage. The AKI is not severe enough, even though there's crescents. I think that I would opt away from plex, and then I would do, after the IV solumetrol, I would convert to a low-dose oral steroid regimen and rituximab, similar to what was proven in the Pexavas trial. You could argue no steroids at all after the IV Solu-Medrol and just go straight to Avacopan. That's the only steroid-free protocol that's been looked at, and that had quite a bit of success too. And you know, I'm sort of 50-50 on doing that one versus the low dose steroids
Would you
and
go
rituximab.
Cytoxan or would you go rituximab?
I think I would use rituximab.
And would you add Avacopan or not?
No.
Okay. Arun, what would you do?
I agree with Bill about the role of Plex. Probably even for a significant kidney injury, he doesn't have it. Most of the studies were looking at creatinines greater than 5.7, and the new ANCA guidelines is 4, around 4. So definitely not from a kidney standpoint. And I don't think his alveolar hemorrhage was that severe. And so Plex is likely not warranted. I would not opt for Plex. In terms of steroid taper, definitely I would give Pulse and then definitely get a steroid-free regimen with Avacopan. But, you know, of course, Avacopan did not have no steroids. There was still some oral glucocorticoids followed, and then you give Avacopan. And in terms of induction treatment, I would opt for the RAVE protocol of rituximab for this patient.
Dr. Reen, what would you do? Anything differently?
Yes, I will actually definitely add Avacopan because there are some case reports recently coming out. A patient is hypoxic. I don't remember this was hypoxic or not. If he was hypoxic, I'll definitely add Avacopan. My choice will be multi-drugs, rituximab, moderate steroid by Paviox study, and some cyclophosphamide, small dose of cyclophosphamide plus rituximab. And later on, I will add Avacopan if he was hypoxic, which I don't remember.
Well,
Not
he
for
wasn't
pulmonary.
hypoxic. He wasn't hypoxic per se, but he wasn't normal either. 93%, 90% is pretty bad. 93%.
Yeah, it's pretty
not
bad.
great.
Yeah. In that case, I will use as per few case studies, came out recently. So I will use Avacopan.
I mean, normal's 95 to 100%, so he was 93.
Yeah, it's a logarithmic scale though. So listen, I get it, and he looked okay. I'm just not, I look at that X-ray and I look at that SAT, and I'm not so sure. But I get it. That's fair. Next slide. I'm going to hand it over to Dr. Corbett. He's going to talk about Pexavas and Advocate trials. Steve?
So
Do you want to control the slides?
No, you're going to control them.
you can go ahead and control.
Fine.
I'll just tell you when to, I'll tell you when to move them. If that's okay, Pravir.
Yep, we're good.
So, if you look at light microscopy, immunofluorescence, and electron microscopy, you had a total of 16 glomeruli, and 13 of the 16 were normal. There were 3 that we saw that had these crescentic and necrotizing lesions. So if you look at the urovasculitis classification for ANCA-GN, which was published in 2010, and they've published since, this person falls into the category of greater than 50% normal glomeruli. So it would be the quote unquote focal class. Go to the next slide. If you look at the outcome of patients with focal class, it's actually quite good. So at least histologically, and his serum creatinine, in all honesty, it was 1.6 at the time of biopsy. The highest it actually ever got was 1.7. Theoretically, he has a good outcome, potentially based on at least the histology and based on his creatinine never going higher than 1.7. Next. The big issue that keeps coming up here is how do you treat it? And there are so many studies that the Eurovasculitis group has done and others with regard to this, that we have a lot of options. But the big one that keeps coming up is, should we plasma exchange or plasma freeze these patients? I think the one caveat, and Bill kind of alluded to it, is this person's anti-GBM negative. If it was anti-GBM positive, I don't think anybody would not plasma freeze. I think that's the one situation where you would plasma freeze them. The Pexavas study, which followed the MEPEX trial, was basically as shown here: methylprednisolone boluses followed by prednisone, either standard or reduced dose, rituximab or cyclophosphamide P or IV. And then the one group got, half the patients essentially were in the Plex group, 7 treatments over 14 days, and then they were on an azathioprine maintenance if they were on cyclophosphamide. Next. This just shows you the taper in the standard and the reduced dose. So standard dose, 60 milligrams, really for only a couple of weeks, and then there's a slow taper down to 30, whereas with the reduced dose, it's 60 milligrams for 1 week, and then it gets halved and then tapered from there. And ultimately, by 15 to 16 weeks, they're already down to almost 5 milligrams. Whereas in the standard dose, they're tapered more slowly and get down to 5 milligrams by 23 to 52 weeks. So the reduced dose, clearly much less exposure to glucocorticoids. And as everyone knows, there was no difference in the outcome of end-stage renal disease or death, independent of plasma exchange or not. And equally as interesting in this study, on the next slide, the reduced dose patients did just as well as the standard dose. So I think that was kind of a game changer for many of us to be able to not have to expose these patients to long-term steroids, which we all know have a lot of untoward effects. Next. So, Brad Rovin and his group got together, and I think this is really great. They didn't wait till the next guideline be completely revamped. They came out and did an executive summary for KDIGO looking specifically at ANCA-associated vasculitis, since there have been newer studies. And as you can see by their kind of algorithm here, the treatment options are essentially the same as the poll that was out there: rituximab with glucocorticoids, or avacopan, cyclophosphamide, rituximab plus cyclophosphamide with glucocorticoid taper. Again, avacopan is in the mix here. And then once there's the disease control and maintenance, either with rituximab or glucocorticoids. What's interesting is in this, and they actually came out in the supplement, or there's a supplement that comes with this. In their original guideline that they came out with, they used the word "and" instead of "or," and they updated it to say, consider plasma exchange for patients with a creatinine of greater than 3.4, which, as was already alluded to in the MEPEX trial, where biopsies were actually done and they weren't done in the Pexavas. In the MEPEX trial, they used 5.7 as the entry criteria for creatinine, but here they're using 3.4. Patients requiring dialysis or with rapidly increasing serum creatinine, or as opposed to "and" patients with DAH who have hypoxemia. So this is kind of the way they spelled out the use of plasma exchange, if you will, which in our patient, and I'm not going to say what we did, but in our patient, he didn't really qualify by serum creatinine for sure. And, we can discuss whether or not he had significant hypoxemia. Next slide. In KI 360, or in Kidney 360, there was this great pro-con, and then there was a summary by Dr. Falk, and the con was done by none other than Dr. Glassick here. Now, I don't know if I would trust anybody that wears glasses like that, but we know Dr. Glassick to be somebody who's reputable and very knowledgeable about the literature and about medicine and nephrology in particular. But his comment was this, and we were kind of hoping he would be here today to expand on this, but his final comment about con was adjunctive use of Plex is seldom, if ever, needed to manage even very severe kidney disease, and its role in severe DAH is doubtful. So I would assume he would fall on the side of not doing pheresis in this particular patient. Next.
So I want to open this up. Now, I know you just heard all this Plex data. I want you to be honest that when you first saw this case, what do you think you would have done? You're looking at the chest X-ray, his CT, his bronchoscopy, depending on what you considered his saturation to be, low or not, iron deficiency, etc. I believe I would have Plex this patient, or I don't think I would have Plex this patient. And this is for pulmonary disease, not for renal disease. Wow. Big drum roll.
Majority. All right.
So we've got 2/3 of people would have plexed this patient, and 1/3 would not have plexed this patient, despite all the argument against it. I don't know. I'm not going to repoll you, but I would be interesting to say that after this conference, would you change your mind? I mean, I have to tell you, I think I might have plexed this patient. I get scared with pulmonary hemorrhage, and but the data does not support that, and I will acknowledge that. But I think that a lot of people kind of feel like I did, that it really worries them, and they want to err on the safe side. Kind of depends how you feel about Plex in general and its safety, and it's not benign. There's anticoagulation issues, there's infection issues, and everything else. So very interesting. Let me just ask. Well, I think he's already answered that. Arun's already answered that. Dr. Abadi, would you have plexed this patient? Were you with an A or a B there? Be honest.
I would have flexed the patient. I don't know, just based on the X-ray. Mild. I mean, he's not hypoxemic, but his CSATs weren't that great. I mean, saturation wasn't that great. So, in retrospect, at the moment, I would have flexed. I think while we're waiting for everything to come back.
Interesting. Good. Okay. Go ahead.
Infection was slightly higher in the people that were plexed, and so that's something to keep in mind.
Absolutely. Steve, you want to walk us through the advocate trial?
Yeah, so then the question is, do we add avacopan, which is kind of another in our armamentarium of treating these patients? Next, as you know, avacopan inhibits the C5a receptor. C5a is important in chemotaxis, which causes infiltration, recruitment of neutrophils, etc. It's also an anaphylaxis. It also really increases the release of histamine, so it can cause anaphylaxis, as can C3a for that matter. But avacopan, has been well shown now to decrease inflammation in this setting. Next. And then this is the trial, and this is thanks to this. David Jane was the lead author in this New England Journal of Medicine article in 2021. I have to shout out to Brad Rovin for letting me borrow his slides, but this just shows you the protocol. Avacopan twice daily with prednisone placebo, cyclophosphamide or rituximab. Cyclophosphamide would be followed by azathioprine, and then in the prednisone group, a prednisone taper over 20 weeks with an avacopan placebo, and then again cyclophosphamide or rituxan. Next. The clinical remission, which was based on the BVAS score of being 0. The BVAS score has 63 points that they look at, and they add them all up, and it has to be 0 to be in a complete remission or in a clinical remission. And so they found that they were identical essentially between avacopan and prednisone group. Sustained remission at 52 weeks, again, was slightly better in avacopan, but similar. Next. Reduction in proteinuria as measured by urine albumin creatinine ratio was essentially the same. It's interesting, it was precipitously better in the avacopan group in the first couple of weeks, and then it more or less was the same out to 1 year. Next. There was a slight increase, if you will, of being free from relapse in the avacopan versus prednisone. So there's a risk reduction of, what does that come out to be, about 64%. Next. And then if you look at EGFR, it was over a course of time was better. Again, the standard error bars overlap, so that's not going to be significant, but it's still, the trend is there. And then the change in EGFR per unit time is also significant, well, not significantly, but better in the avacopan group. Ultimately, avacopan was considered non-inferior but not superior to prednisone. And so they're saying it's not better, but I think many of us would rather use avacopan than long-term prednisone if we have that option. And I will turn it back over to Roger.
So I want to get everybody's opinion on this. Poll number 3, would you give this patient avacopan with induction? Simple yes or no. Pretend it's available, pretend it's not, you know, you can get it.
You've convinced them. Yeah, pretty convincing here. Okay.
Yeah, it's about 3/4 yes and 1/4 no. Arun, I think you were at the GlomCon. I don't know how much attention you paid during the vasculitis session. I was kind of busy working on my slides, but I think there was some mention of subsequent, you know, studies that tweaked out some of this data. In other words, and you could tell that could be making this up completely, but do you think there's a difference between avacopan in severity of disease, presentation, and whether it's P-ANCA or C-ANCA or C-ANCA?
No, there was no difference. I mean, it worked equally well with all anchors considered. But of course, Roger, the main issue is that the avacopan data is very concrete for up to 1 year. There are few studies looking at how long do you want to continue, and the signal for benefit is there now for even year 2. So that's a very commonly arising question. If I've started someone on avacopan, can I continue it beyond 1 year? And the current consensus, even with Dr. Jain, is that he would continue avacopan.
Can I convince you not to use it because this is a relatively mild disease?
So personally, I would like to use this in this particular patient because he's already immunosuppressed. He's got ankylosing spondylitis. He may flare up for some other reason where they would use prednisone. So just to reduce his total prednisone lifetime duration, use of glucocorticoids for this patient, I would like to avoid. But that's, again, if he gets the medication and it gets approved.
Yeah, well, that's part of that's the premise, and I think that's a really good point. Dr. Reen, you said you wouldn't plex, but I think earlier you would want to give avacopan.
Yes, I will like to give avacopan for the reason that patient is hypoxic. Other thing I'll use prednisone a little longer if he was in kidney failure. I think his creatinine is reasonably high. So I'll use it for a longer time. So my use of avacopan is not totally steroid reduction, but hypoxic presentation of this gentleman.
Next slide. So I think let's move on to poll number 4. Now this gets into a whole nother issue. Does this patient need maintenance immunosuppression? We've got 5 options here that I made up. One is no, this is really this is the Humira. This is self-limiting and the patient doesn't need it. That's the approach we often take when we know it's related to hydralazine. Number 2, no. This is MPO vasculitis, low relapse rate, does not justify automatic maintenance immunosuppression. Number 3, yes, azathioprine for some finite period. Number 4, yes, some dose of rituximab every 6 months for some finite period. Or number 5, which is yes, some form of immunosuppression indefinitely. This patient has a very bad disease. It has somewhat of a risk of coming back, and I'm going to continue something indefinitely. So let's see what we get here.
Come on, more votes. We can't see what you vote for.
Come on, people, vote. We got to.
All right, come on, a few more. All right. Seems like we do have the majority.
Yeah, we can show it. The biggest vote is for rituximab every 6 months, and pretty much spread around the other. We've got a couple Humiras and a couple people that want to give immunosuppression forever. Bill, what do you think?
Yeah, I mean, even if it is from the Humira, I like the idea of no maintenance, but the danger of a flare, if it's not from the Humira, is too much to not give some sort of maintenance. And so my standard maintenance has been Rituxan. I do a little bit less total duration of maintenance for MPO compared to PR3, but I usually go out to about 3 years. And I use Rituxan steroid-free for maintenance. So I would pick 4, number 4.
Anybody feel strongly about the other options? No. Next slide. So this is a really nice paper that Patrick Nachman put out a couple of years ago about the best maintenance therapy for, it's only 2 pages long, but it really goes into the major factors of maintenance consideration. So the first is the risk factors for relapse. One, of course, is PR3 vasculitis this patient does not have. Lung involvement this patient does have. This is not PR3, but certainly PR3 after treatment is a big risk factor for GPA relapse. History of prior relapse, no surprise. And a little bit about the initial induction therapy. So if you use something other than oral cyclophosphamide, but I don't think this looked at rituximab. I just think it compared oral cyclophosphamide to IV cyclophosphamide, MMF, or methotrexate, that you have more relapses. So what about choice? And this is really distilled here, but basically what I was able to find about the maintenance choice to prevent relapse was that, and this was early data, when they first, they were using, and I'm going to go into this a little later, the length of cyclophosphamide that they would use, that they started using azathioprine, and they found out they had the same outcome as in preventing relapse as long-term cyclophosphamide, but a lot less, obviously a lot less toxicity. Subsequently, azathioprine was actually found better to be MMF in preventing relapse, which is interesting because the ALMS follow-up trial found just the opposite. Azathioprine, interesting, was about the same as methotrexate in relapse and safety. I thought that was interesting. I've used methotrexate in several patients only because they haven't tolerated just about anything else.
But the ALMS was in lupus.
Yes, it was in lupus, but it, it's still autoimmune disease. It's interesting that one disease would be that much different. It's kind of odd. Adding belimumab was not any help in at least vasculitis as far as relapses. And they definitely found that rituximab has less relapses than azathioprine. And what about maintenance length? And there's a whole paragraph, but really nothing is said. And the only thing definitively I could find was that if you do use a B-cell depletion regimen, that if you are ANCA positive and you become ANCA negative and you have persistent B-cell depletion, that no patients had a relapse. So if that's your goal, you would want a negative ANCA and you would want a B-cell depletion, and you will not relapse, but you also may pay a price from the immunosuppression. So it's kind of interesting that we showed this before, but this is the new KDIGO guidelines for ANCA-associated vasculitis, and they don't really go completely with what was in the Nachman article. They say that either rituximab or azathioprine for maintenance, they are saying anywhere between 18 months and 4 years, which is a huge difference. And I think that pretty much everyone would think that there should be some maintenance. I mean, I don't know. I kind of feel like Bill, that even if I had hydralazine, I might give another dose at 6 months just to be kind of on the safe side. But that's a huge, that's a huge difference in timing and length and decision making. Arun, how long would you treat this patient for, maintenance wise, and what would you use?
So maintenance, I would continue rituximab for this patient. And I would continue just like a regular ANCA vasculitis with just using the main Ritsan 3, which is not eventually after 1.5 years, making sure you check the B cell count to guide further rituximab therapy.
So you do guide it by that?
After 18 months.
After 18 months.
What's the count you're looking for? CD9? Are you looking at CD19 or?
Yeah, 0 complete B cell.
0 or less, not less than 5, actually 0.
No, 0. Yeah. Complete depletion.
Dr. Obadi, what would you do the same thing?
Yeah, I think I usually track them up to 18, and again, I actually have a patient just like that, and he's B-cell depleted, so we're good. If they're not, then obviously have to look for refractory and maybe try obinutuzumab. I have a patient that we're going to do OB on because he's just relapsing despite being on rituximab. So it really depends on the B-cell count.
Would you give, last time I looked at it, there was the 500 every 6 months. There was another, there was 1 gram every 4 months. Start with 500 or a gram?
I usually do a gram actually, especially in these patients who tend to relapse, because ANCA is notorious for relapse. So I would err more on the side of caution that way.
Do you follow IgG levels?
I do, and if it's below 300, we usually give them some IVIG.
Great. So Steve, you want to tell us what they did?
So he ended up getting a gram of methylprednisolone for 3 days, followed by prednisone, with marked improvement in his symptoms. He actually was getting topical steroids for his rash, which actually did improve the rash even before he got the IV methylprednisolone. Plex wasn't done given the mild severity of his AKI and given the mild severity of his DAH, even though the x-rays did look horrible. He was doing fine, was completely asymptomatic. He got rituximab, ultimately a gram, two doses, 2 weeks apart. His prednisone was tapered according to the Pexavas, and he was down to 5 milligrams by 5 months. And now rheumatology is following him and managing him. He's on azathioprine 50 milligram maintenance at this point.
Boy,
Go ahead.
Sorry, I'm sorry, Steve.
I saw him literally 5 months after the biopsy, and his MPO, as Roger alluded to, for some reason in the hospital they didn't actually quantify it was greater than 8, was down to 3.3, which is still higher than 0.9, which is considered negative. The PANC was less than 1 to 20. The SED rates and the CRP, which were off the charts, were completely normal now. His creatinine is 1.27, his GFR is 73. His urinalysis is completely normal, no protein, no microscopic hematuria, and his urine albumin creatinine ratio and protein creatinine ratio are normal as well.
So, that's a really good response. And it's interesting, he's only using 50 of azathioprine. It kind of fits pretty much our whole discussion today, no Plex, rituximab, although I think the majority of the group is running this, they would have given, we would have probably opted for rituximab for maintenance for some variable time. And I think if I were going to use azathioprine, I would use a higher dose, unless they find out that he's that whatever enzyme deficient.
They checked him. He was TPMT negative.
Okay. I knew you'd know it because I certainly don't know the enzyme. I'm going to really quickly, I want to just talk about, I'm not going to talk about these trials. I just want to show you what an incredible history we have of evolving to the point we are today from, way back in the 1990s to most recently Pexavas, next slide, in 2020. And what's not here now, next slide, is the Advocate trial 2021. So we've come such a long way, and we've really changed the outcome of this disease. But I want to go back, back to the early 80s before any of this stuff was available. I was a fellow in 87, and we were going by the NIH protocol, which, next slide, if you look at this was published in 1983. And if you'll probably recognize this first author, Dr. Fauci, before he was the face of COVID. This was a retrospective, prospective clinical therapeutic experience. It's a little misleading. It was prospective that they used cyclophosphamide, but it wasn't randomized to anything. But the point, I want to make a few points, that before we had any treatment, patients with Wegener's or GPA, this is verbatim, survived 5 months, 82% survival, dying within a year, 90% within 2 years. So this was pretty much a universally terminal disease. Steroids changed this, but it only really improved survival to about 12 months. And the big difference was when they started using cyclophosphamide in 1973. And they published this in New England Journal of Medicine. When they did, they had a 12-year period, 18 patients, 15 of whom had received cyclophosphamide. Of the 15 patients, only 2 died of their disease and 1 died of unrelated causes. So this was a huge difference from a universally fatal disease to a very survivable disease based on cyclophosphamide. The interesting thing about it, though, next slide, is that their treatment regimen, and I remember using this, for quite a while, was to give cyclophosphamide 2 milligrams per kilogram per day orally, but this is for at least a year after a patient was clinically in complete remission. And complete remission was defined as the complete absence of active disease. It's a little bit up to you, but pulmonary infiltrates, Renal function must stabilize or improve with no further evidence of renal sediment. Proteinuria may persist for months or years, but they really want the hematuria to go away. So you could see easily giving a whole nother year, at least after you achieve this. And then the taper is very slow. Tapering schedule should be done at 25 milligram increments every 2 to 3 months. And if you're getting 150 milligrams a day, which is an average dose, and maybe even a low dose for some of these patients, you were talking about at least 3 years of cyclophosphamide. And when you add that up, that's a lot of cyclophosphamide. And it's no surprise that that the reports of bladder cancer, which was the biggest, came out eventually. And not even talking about infertility and the like. I recently had a patient who I treated for vasculitis years and years ago. I mean, it was so long ago I hadn't really thought about it. And then he started having some blood in his urine, and he even had a history of stones, but it bothered me. And I sent him for cystoscopy because of the concern. And sure enough, he did have bladder cancer.
I mean, on average, it took a year to go in remission in these patients. And when you look at, when you looked at we go back and read the paper. The other thing too, everybody needs to keep in mind, because most of you are young, is that there were no ANCAs then. They would follow, the only serologic test they followed was a CRP. I remember this when I was a medical student, the allergy immunology people who would manage this. So they were following SED rates and CRPs to see what they would do. We didn't have the advantage of having an ANCA to see if it was, going negative on us, or, and the clinical findings, and, obviously the laboratory tests looking at proteinuria and renal function.
And one other point is that this is probably why there's this huge myth out there that oral cyclophosphamide is so toxic. It's not necessarily that oral cyclophosphamide is so toxic. It's that oral cyclophosphamide for 3 years at this dose is very, very toxic. If you use what we did in lupus in a collaborative study group with a short-term, 6 to 8 weeks of oral cyclophosphamide, the overall dose is much, much less than what it is here. And so everybody got very, very afraid of oral cyclophosphamide, when really it has to do much more with accumulation of dose as opposed to just the route of administration.
Yeah, I do want to point out this is GPA, which is a worse disease. I don't know that this horrible prognosis would have applied to GPA, but I suspect it would. It would just take it a little longer. I mean, cyclophosphamide was a game. It saved lives. The incredible thing is where we've come from there. Now we're talking about, treating it and how long should we treat the patient to keep them alive? It's really quite remarkable. It's a great story. It's a great success story that spans 40 years, and it's fun for me to see, and Steve and I, we're the older ones in the group probably, to have seen the the evolution of this, because it was no fun giving somebody cyclophosphamide for 2 years.
Keep in mind, not to break in, but the eurovasculitis group was huge in a lot of these studies. I know the more recent ones weren't necessarily them, but a lot of those, azathioprine versus cyclophosphamide for maintenance and so on and so forth, MEPEX, that was all eurovasculitis. I mean, they were really, David Jane and that group were way out in front.
They were way out in front. Yeah, absolutely. And that timeline I showed you, there's, they all have names and they all took one step next, azathioprine versus this versus that, Plex versus this, rituximab. So there's one after the next. And, I could have gone through them, but that would have taken a big cheat sheet. And it's really a moot, because I think it's incredible where we've gotten to. And it'll be interesting to see where avacopan fits in the final analysis. So with that, I'm going to wrap this up, unless anybody has any strong comments or what else. Great case. Thank you very much, everybody, for discussing. And I'm really glad to have Dr. Abadi and Dr. Rajasekaran join us today. We'll keep you involved. The more opinions we get, better. The only shame is that Dr. Glassick wasn't here to defend himself with that silly picture. But be that as it may, maybe we can crop it up some other time for him and surprise him. So thank you very much. We'll see you guys in a couple of weeks. Keep your eyes open for an email, and everybody stay safe.